Thank you.
None of the authors have any financial disclosures to make pertaining to this study. Next. Coronavirus have off lately suggested us and shown us the ability for it to change the disease. Recently, a publication by Finlay et al. Also suggested that the non-communicable diseases like diabetes, cancer, and obesity are now becoming communicable because of the changes in microbiome affected by bacteria and virus. Also, the medical world has now started emphasizing on the role of microbiome and has also proven that role of microbiome leading to multiple inflammatory disorders and cancers of the systemically. Our group and multiple other groups have shown in the past that there is a role of inflammation which drives eye rubbing and in turn which leads to keratoconus. So, we now know that inflammation leads to eye rubbing, which leads to low levels of LOX and collagen, which leads to keratoconus. But the question is, where is this inflammation coming from? Like other systemic conditions, is the ocular surface inflammation also driven by this unknown bacteria or the microbiome? We wanted to study that whether the microbiome is leading to this ocular surface changes or it's also leading to keratoconus. But the challenge here was, how do we study the microbiome of the eye? Because 30% of this patient bacteria cannot be cultured or stained. So how do we overcome this challenge? We decided to do the microgenomic sequencing of this bacteria from the ocular surface and study the disease pathway. This is how the study was designed. It included 3 arms: the genomic analysis, the ocular surface immune cell analysis, and the inflammation arm from the tears. It was a prospective interventional study with prior ethics committee approval and patient consent. We had a strict inclusion and exclusion criteria. Patients with prior contact lens use, history of eye rubbing, history of any prior eye surgery or treatment were excluded from this study. We included 35 healthy eyes and 54 keratoconic eyes spreaded over different grades of keratoconus. All the patients underwent detailed clinical and topographical evaluation before getting recruited in the study. What we did was we collected the ocular surface from the lower fornix and the ocular upper fornix. We extracted the DNA from this ocular swab and performed a 16RS genomic sequencing. And the unknown database which we found from this was compared to the known database to classify the new disease pathology. This is how the tree of bacteria looks like, and this is how they are classified. What we found here is all these bacteria were found in the patients of ocular surface of this patients included. Interestingly, the tenericutis and the thermocutis were found to be higher in keratoconic eyes and which were not present in the control arm. Also, the proteobacteria, which is the bad bacteria for the keratoconus, and the acinobacteria and the firmicutes, which are the protective bacteria in keratoconus, were deregulated, suggesting that yes, there is a role of bacteria which leads to disease called keratoconus. And also interestingly, we found that the load of bacteria, the abundance, and also the various unclassified microbiome genetic bacteria were increasing with the increasing grades of keratoconus. Next question was, how do these bacteria influence the immune trafficking cells on the ocular surface? We devised a novel technique where we collected the ocular surface wash for these patients and stored in these tubes. They were then transported to the lab and flow cytometry was done to study the specific cell types and to quantify the same. What we found was that the leukocytes, the neutrophils, and the neutrophils T lymphocyte ratio, which is the protective mechanism, was lower in the keratoconic group compared to that of controls. Also, the activated neutrophils, the T lymph cells, and the macrophages, which are the harmful cells, were higher in the keratoconic group compared to that of controls, suggesting that yes, there is the altered immune cells on the surface can drive the disease. Is there an interlink between the bacteria and inflammatory cells? We did tear analysis, and what we found and matched with the published literature was IL-8, CD121, and the MPO levels, which is affected in keratoconus, was significantly correlated with actinobacteria. Proteobacteria positively correlated with the inflammatory markers IL-17A and IL-12, which is known to affect the LOX and the collagen levels. The lower the LOX and the collagen levels, which in turn leads to the keratoconus disease. Perforins, which has the cytolytic effect, which kills the cells, was higher in the keratoconic group, positively correlated with the bacteriocytes. And if we do a surgery on this kind of patients, post-operatively they can land up into haze. Thus, altered microbiome can lead to altered ocular surface immune profile, which in turn can lead to increased inflammation on the surface, which drives the disease. But how does this disease impact the disease clinically? It can lead to disease progression where we have not operated the patients. If we operate with cross-linking, post-operative complications like infiltrate and haze, and also failure of treatment of cross-linking can happen. At this point of time, inflammation can be stopped with medications like cyclosporin, lifitegrast, and 3-halose. But how do we stop this unknown, unclassified bacteria? We are currently working with pharma companies to develop these newer antibiotics, which are the epigenetic modulators to target this cluster of unknown bacteria. And the ocular topical probiotics would be the wave ahead to control this microbiome. Thus, this is the first ever reported study for the role of microbiome of unclassified bacteria in keratoconus. Altered microbiome affects the keratoconus disease, which possibly drives the eye rubbing and inflammation on surface, and we need to modulate this inflammation and eye rubbing by blocking the bacteria. Thank you.